morning all once again. So last year at this very symposium, I spoke about viremias after transplantation, and the title of my talk, some of you might remember, was A New Challenge in Transplantation. I've actually developed over the last year and would like to talk to you about the BK nephropathy, which is not a challenge, it is actually a problem. So what I hope to cover in the next 15 to 20 minutes is help you understand the new challenge that we are facing in the outpatient clinics after all the surgery is done, give you some evidence about the monitoring and treatment of this condition, and also look into some of the new publications on the outcomes and also the risk factors which are associated with it, but also share our experience. And I would also like to hear about you and your experience when it comes to BK and BK nephropathy. So is it a problem in your practice, primarily for the nurses and for the nephrologists in the audience? Yes or no? You see it a lot? So it is a problem if you look into the literature. So the BK virus-associated nephropathy leads to the allograft loss in 50 to 70%. And it is a recognized modifiable risk factor for the chronic allograft injury. 20 to 40% of solid organ transplant recipients will have the virus in the urine detected, and 12% of those will progress and have viremia. Excuse me. So why do we have suddenly this problem? It is a success of the more potent immunosuppression, particularly in the last 15 to 20 years, but not only that, it is also due to the more regular surveillance, which we've been doing since 1995. It was first described in 1971, and it was named after the patient who had a kidney transplant in Saudi Arabia. But actually, it wasn't after the quarter of a century later where we acknowledged and appreciated that BK is a problem for our renal transplant recipients. As humans, we are the natural hosts, and the infection is usually acquired in the early childhood as tonsillitis, with more than 90% of prevalence in the adults. The monocytes, after the infection in the tonsils, the monocytes carry the virus all over the body, and it is usually the renal tubular and ureteric epithelial cells which this virus resides in and is usually maintained in the latent state. You will find intermittent viral shedding in all hosts, particularly during the pregnancy in women. But BK virus-associated nephropathy, as described in a really good paper from now nearly 15 years ago, can lead to a 5-mil GFR reduction monthly if not recognized and not treated. Also, in CJs, a couple of years after that, there was a report that in a large series conducted over 10 years, that 60% of grafts were lost due to the BK nephropathy. So how does the BK cause the damage? It's probably not best for me to talk now that I have my colleague infectious diseases consultant here, but I will try. It's a virus that remains in a latent state with a very minimal viral episomal replication if you are immunocompetent host. However, in any immunosuppressed state, this circular double-stranded DNA can cause a problem. It encodes for the microRNA, which essentially reduces the susceptibility of the infected cells to the CTLs. And there are no antivirals to date to tackle this virus. Now, this is a really, really great paper which has been published last year on the biology of the viruses, and I really urge you all to read it because it's an absolute fantastic overview, and it explains why we are unable to so far develop antiviral medication, mostly due to the early and late transcription proteins, which are central part of the replication process of this virus. So once it starts to replicate, what does it actually do? So it causes the injury to the tubular cells, hence you can detect it in your urine and also the uroepithelium. But most importantly, it causes the lysis of the cells, and you get viral seepage in the urine and the interstitium. And if you then have the destruction of the tubular capillary walls, you will then have the viremia. So how does that look histologically? The very much pathognomonic are the BK inclusion bodies, and it is confirmed now in a paper, which was a really good study from 5 years ago, that the BK load of more than 10,000 copies per mil in the blood is associated with already histological changes in the renal allograft. It causes the interstitial fibrosis and tubular atrophy, and because it causes these changes, this can sometimes be mistaken for various types of rejections. Looking retrospectively, a lot of studies are now saying that actually perhaps some of the early graft losses in the 90s, 80s and 90s were due to the BK and not the chronic rejection. There are 3 gradings when it comes to the histology. The minor one is the grade A, where there is no inflammation and cytopathic changes. And this is actually the stage where you would want to recognize your BK and to start aggressively treating it. Stage B is the tubular atrophy. You already have some fibrosis, some scarring, and ongoing cytopathic changes. And then, if not treated, it progresses to the tubular atrophy, interstitial fibrosis, and chronic inflammatory changes, which are irreversible. Some reports state that if untreated, from the time when you have the BK in your blood detected, it takes 6 to 8 weeks to start seeing some of the changes. Now, this is not a long period, and we'll then look into the monitoring and also some treatments and the practice worldwide in the later slides. And also, we have to be aware of the false negative biopsies. So if you're not getting the corticomedullary junction, just like for the FSGS, for the BK, you might miss it because you will find it in your interstitium. And if you miss that bit, you might get a false negative biopsy. So how do we measure viremia? This really is dependent on the laboratories. You can measure it in the blood, and this is the gold standard at present because it has 100% sensitivity and a very good specificity for the BK virus-associated nephropathy. Viruria, we have moved away from that, is a marker which is not as specific when it comes to the nephropathy. Decoy cells were initially measured in the 90s. Not a lot of centers are measuring those still. And some of the centers have actually suggested that we should measure the antibodies. However, some of the very few studies where the BK virus-associated nephropathy was studied, when they compared it to the antibodies, there was no association with it. And my colleague is shaking the head, so it's true. If we want to look into what part of our immune system is responsible for actually clearing the BK, is your cellular adaptive immunity. It's essential for the clearance. So if you have the high CD8, you will have the low BK. And what do we do when we transplant an immunosuppressed somewhere? We just basically suppress those cells. It can take up to 5 months to start to develop anti-BK specific cells. And I would be just interested to know from colleagues around the world and in other centers, do they routinely measure the BK cells in their renal recipients who have the BK viremia? So moving on to how often should we check? There are 2 guidelines which seems to be used by most transplant centers, and we look into the paper which talks about how well are those guidelines followed. So KDIGO suggests that we do monthly testing for BK for the first 3 to 6 months post-transplant, and then 3 monthly until the end of the first year. And the AST guidelines is actually much stricter on this and recommends the minimum monthly for the first 6 months, then actually every 3 months until the end of the second year. And they have published recently a paper which says that actually by following and by testing for BK, following the AST guidelines, 80% of the at-risk patients, at risk for BKVAN, can be identified before any significant renal allograft impairment occurs. And this is exactly where you want to find yourself and not anywhere later. At Almost Street, we do monthly in the first year, and then we do it as part of our annual screening. But this is our protocol. In practice, we might have 1 or 2%. Everybody gets more frequent monitoring. So how often are the centers around the world actually following any guideline that exists out there for this? So there was a paper from a couple of years ago which was published by the work group for transplantation within the European Society of Pediatric Nephrology. And it seems like that majority of the pediatric centers when it comes into Europe are testing for BK at 3, 6, 9, and 12 months post-transplant. And that those colleagues consider the BK log of 4 4 log copies per mil to be the significant and something that worries them, and the range was between 3 to 6. And actually, it is astonishing that 5%, up to 5% of our colleagues, 5% patients had already BK virus-associated nephropathy in the first year post-transplant. Second paper from the comes from the New England Beacon Consortium. So they have surveyed their region, 15 adult renal transplant centers, and actually, when it comes to joint AST and KDIGO, more than 50% use less intense monitoring. Nearly half monitor for shorter duration than recommended, but all centers actually reduced the immunosuppression before the threshold for reduction was reached, which is 10,000 copies per mil. What was interesting was that 60% of the centers also lose the antiproliferative leflunomide and ciprofloxacin, despite the clear evidence of efficacy in the literature. So how do you treat the BK viremia? According to the KDIGO guidelines, if the BK is persistently less than 10 copies per mil, and you can take the freedom to how to define persistently, and they advise that, that we reduce the tacrolimus and aim for the levels which are less than 6, and reduce MMF to the total daily dose of less than 1,000. And their advice is to do both changes together. Now, a lot of centers have in the outcome study reported that they feel reluctant reducing both and just fear of the rejection. The AST advises that if you have presumed BK virus nephropathy, which is your persistently elevated log of more than 10,000 copies per mil, or if you have a biopsy-proven nephropathy, that you should either, there's two options to follow, first reduce tacrolimus, 25 to 50%. If that doesn't improve your BK viremia, then reducing 50% MMF and then stopping the MMF. Or you can do it other way around, 50% of MMF reduction, which then follows by 25 to 50% tacrolimus reduction, and then further MMF reduction, basically seizing that antiproliferative agent. So looking into the literature, what treatment for the BK virus-associated nephropathy, apart from the reduction in immunosuppression, exists? Not much, really. There's no antiviral agents, and there's no prophylaxis that has been currently approved. The overall conclusion is reduction in immunosuppression with stopping antiproliferating agent and really running your TAC levels low, regardless of the time post-transplant. Now, this can cause some anxiety amongst the nephrologists in the first few months after the transplant. Some centers have, some studies have advised that we change from tacrolimus back to cyclosporin, which this would probably mean a lot of our patients now, because, and this is based on some in vitro studies which show that cyclosporin inhibits the reactivation of the virus. Again, leflunomide and ciprofloxacin are used by some of the centers, but there isn't really that much firm evidence for it, although we use it at the GOS as well. I think more as an act of the desperation than anything else. IVIGs, I think they are advised together with the reduction in immunosuppression. We will struggle in the UK to get the IVIG for that indication. It is very difficult to get it even when you have a child with antibody-mediated rejection, needless to say, for a BK nephropathy. But actually, it is the time. It's your overall reduction and the time. You need to allow for the time, if you have it, for the BK to come down as a response to your reduction. Now, a couple of slides on the outcomes. So there is a study from this year, which was published in Pediatric Transplantation. It comes from colleagues in Finland, looking in pediatric renal transplant recipients. If you do not treat, you don't do anything, 50% of your BK viral-associated nephropathy, you will get the onset of BK viral-associated nephropathy after 6 weeks of detecting your viremia. You don't have much of the time. You should be really acting on early. 10 to 30% had false positive biopsy in the early stages, and actually 20% of all of their pediatric renal recipients developed viremia. Interestingly, their monitoring, they said that they had 77% who detected BK in the first 3 months post-transplant. And when they compared the GFR at the 1 year post-transplant in the BK positive group, and this is not BK nephropathy, this is BK viremia, the GFR was 54 compared to 71 in the negative group. So it's really significant difference. They didn't find it. It was associated with a donor type or age. And actually 30% of these patients went on to develop nephropathy, with 1 graft being lost. So So what are the risk factors? If there isn't antiviral medications at present that can help us, what can we do? Can we identify some risk factors? So this was from this year as well in the Journal of Clinical Virology. You can see what are the factors which are associated. The one in bold have been proven to be statistically significant, definitely tacrolimus and the use of the polyclonal antibody at induction, deceased donors or male recipients, but not previous transplants, interestingly. Ureteric stent and prolonged cold ischemic time, I think this was the observation from the mid-90s and still persists. So not much we can do about it when it comes to kidney transplantation, apart from maybe tackling this cold ischemic time. And also its association with delayed graft function. And that can probably be histologically comparable and understandable because you're having the ischemia hyperperfusion injury as well. And that injury to the kidney itself, which carries this virus, can then allow the virus to reactivate. Looking into the viremia, having more than 185,000 copies per mil initially is a significant risk factor. There was a paper now nearly 15 years ago from Brennan in the American Journal of Transplantation, which really, it's an old paper, but it fantastically addresses, and it says that the net state of immunosuppression, and not really a specific drug, is the risk factor for the BK, and particularly says that ATG or MMF are not risk factors for BK. So just to finish off with one of our current patients, and also would like to ask you if there's anything that you would have done differently. How easy is it actually to follow these guidelines on monitoring and actually on treatment when you're sitting in clinic with your patient? So we have, Steve and I look after a 10-year-old boy who had end-stage renal disease secondary to congenital nephrotic syndrome, genetically confirmed. He had his first deceased donor transplant in 2013, and sadly this was lost only after a week because of the severe antibody-mediated rejection. He then underwent a second living-related kidney transplant in 2016, and this transplant was one of our high immunological risk transplants. He had a pre-existing donor-specific antibodies with not that high MFI value and weakly positive B-cell cross-match. So we opted to use alemtuzumab for his induction and then used tacrolimus, MMF, and prednisolone and his maintenance immunosuppression. And then we did very frequent aggressive monitoring of the DSAs because we worried about the rejection. So on day 6, he had a marked rise in his DSA MFI. We biopsied him. There was a very strong C4D staining, but actually he had a very stable creatinine, and we opted not to do anything about it and just to monitor. He remained stable with a good renal function for the next 12 months. And then at 12 months monitoring, he had BK detected with a high log of CT26. And this is where we get now a little bit confused because our laboratory at the Thomas Rees Hospital does not report international units per mil or copies per mil anymore. For BK, we get CT, which is the cycle threshold, meaning that this is the number of cycles that the fluorescent needs to reach and go beyond the baseline and the background. It is thought that if you have a CT less than 30, that is a severe BK, but there is no correlation with how many copies per mil, and if it is more than 30, that is considered to be a low-level BK. So what would you do for this patient? He's on TAC and MMF and not on prednisolone, for my recollection. We just have a BK detected. He's on TAC and MMF a year after his second transplant, and he's a high immunological risk. So, no, they actually were not detected. At 12 months, they were not detected and remain not detected since, but they were negative at that time. So, what we did, we reduced MMF by 10% in November last year. And this was a very difficult decision to make because some of my colleagues who are sat here in the room have said, but what about the memory cells? And we talk about these memory cells, and there's a research trial going on here by Professor Dorling at Guy's. There isn't much evidence of memory cells really, but there is a lot of evidence saying that the BK is not that, that the BK is a big problem. So we biopsied him in March, and he already had a stage A. With our 10% reduction, he already had stage A. We stopped the MMF and said we just really have to stop that but that was too late already. He had a second biopsy in July this year and was already a stage B, and that just on a low dose of TAC and small dose of prednisolone. We have added ciprofloxacin and leflunomide just as an act of desperation. However, if you look into his GFR, a year ago, his GFR was 86. This is from November 2018 when Steve saw him in clinic, it's 33. And just for the interest, the BKCT is between 30 and 32. His TAC levels are around 4. So in summary, the big problem post-transplant is the BK virus-associated nephropathy, and gathering from the evidence and from our personal practice, really frequent monitoring the first 12 months is advisable, and very early reduction and aggressive reduction in net immunosuppression. However, this needs to be taken into the context with individualized approach and balancing the risks until we get an antiviral on board. Thank you.